Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Up to 40% of patients with diffuse large B-cell lymphoma relapse within the first 2 years after primary treatment. Due to its aggressive nature, patients need dedicated support throughout the care continuum. Our guest today shares what that looks like and how to strengthen those relationships with patients and their families. Robin Atkins is an oncology certified registered nurse in outpatient symptom management triage in medical oncology at Virginia Oncology Associates in Norfolk, Virginia.
I think it's important to, first of all, besides the typical, what is their learning style, language barriers, getting past all of that, I think it's important to listen for meaning when you're talking with patients and caregivers who are undergoing cancer treatment for lymphoma. Hearing the meaning behind what they are saying and in what they're saying, and then incorporating that into the general care plan is a big thing that I try to do very consistently with patients and families when I'm talking with them. It takes time, it takes practice, but it's extremely effective in making the whole process more patient-centered and validating the patient's perspective and priorities.
What do shared decision-making conversations sound like?
So we're in the outpatient setting, and shared decision-making is a two-way conversation. You have the clinical provider team, the nurse and the doctor and other advocates that participate in the patient's care, contributing by providing information, explanations, and sometimes direct instructions. However, we need to hear back from the patient or the caregiver, and both, if there's a caregiver involved, and assuring that they've understood what's been said. And one of the phrases I like to use a lot is, what this means to you is. So if I say something complex, I like to follow it up with what this means to you is, because that's really what they want to know is, yes, that's a bunch of medical information. It sounds complicated, but what does it mean to me? So effective care planning and conversations with patients and caregivers includes an exchange of information where both parties are listening, but also we concede with what the priorities are with the patient.
How important is it to engage caregivers?
I think it's important that your office processes include the provision of time and space to have the physical presence of the caregiver or the family member as well as the patient. If you exclude the caregiver from the physical space where care planning and caretaking is happening in the office, then you're going to miss those key opportunities for teaching, for setting up appointments for imaging or referrals, and how and why those things are happening, getting the real information that patients sometimes just don't disclose, or they're just so information fatigued that they just don't want to say it again or repeat it again. So caregivers being included in the care planning, it needs to be a priority in the facility. You need to have space and time for it. There needs to be face-to-face contact, I think at least on some regular schedule, because we know we can't always be face-to-face, but face-to-face contact has to happen.
How can care providers build trusting relationships with patients?
So I think to help encourage that and build that bond, we first have to be authentic in how we approach the profession of nursing. We have to commit ourselves to being available. We have to circle back to emotionally based concerns that patients and caregivers have at each follow-up. We have to be astute to body language, facial expressions. The absence of communication is important to recognize as a potential need for more communication, and opening the door for emotionally loaded conversations such as, if you've got an adult who has children who are both bickering for the primary caregiver slot, and helping the patient set those limits with those caregivers. and choose a caregiver.
How do we make sure patients are receiving the best possible care?
So I believe that primary oncology nursing works best, and it works best when it's primary to the patient, meaning that the patient sees the same nurse or nurses each time they come in. That continuity of care is very important, where that head-to-toe assessment can occur, and the patients don't like repeating the story over and over to a new person. And so, knowing that about our patients, we need to provide that continuity so that when they come in, they're picking up where they left off. So, clinical visits with the nurse is part of where the assessment happens. Assessments happen largely in our organization through the telephone triage department that we have set up, which is unique, I feel, to our organization, but it can be easily duplicated if that's the priority for the facility. But patients have access directly to a symptom management triage nurse from 8 to 5, Monday through Friday. Also on the weekends, we have symptom management nurses that can be contacted and help facilitate communications between patient concerns and the provider team and get care implemented right away, or interventions or testing or whatever right away. So patients have to know how to reach you during and after business hours, and they need to have access to the people who can help them with the question.
Thank you, Robin. We have more resources on effective practices to support patients in the show notes. This episode was made possible through support from AbbVie, Genab, and Genentech. Until next time, for the Cancer Buzz team, this is Summer Johnson.
This show is a resource of the Association of Community Cancer Centers.